part one of a special two-part program on current approaches to pediatric surgery. This is Audio Digest Surgery, Volume 16, Number 3, for the week of February 12, 1969. In this issue and the next, you'll hear some of the most practice-useful discussions as presented at the postgraduate course in pediatric surgery at the American College of Surgeons Annual Clinical Congress, and as presented at a Johns Hopkins Hospital postgraduate symposium on difficult problems in pediatrics and pediatric surgery. In the adult, it's usually not necessary to consider many of the emotional aspects of hospitalization and operation because the mature individual can cope with these. But in the management of the child, who may be leaving home for the first time, there are several important considerations that should be a part of management, as Dr. J. Alex Haller, Jr. of Johns Hopkins University points out in his discussion of emotional preparations at home and in the hospital for operation. Dr. Haller?
In our approach to the admission of a child to the hospital, it has seemed to me that one of the most useful concepts is that this represents an adventure. Children are very familiar with this concept of an adventure, which does not carry with it only safe aspects, but that there are usually painful aspects of adventures. There may be dangerous aspects of adventures. But high adventure is a very real part of a child's early experience and of his life. And if we look upon a hospital as a place in which an adventure is taking place, and I think as surgeons we're aware that this is not inappropriate, then the child comes in contact with an environment and with personnel who will significantly influence the results of his hospitalization and his experience. Now, the parents, of course, will come first in contact with the child as a consideration is given to the operative procedure and its indications. And it has become quite obvious to me that most parents do not know what is going to be done in the hospital, nor do they know very much about the operative procedures with which we are so familiar that we often overlook important details. In addition to giving this information to the parent from the standpoint of having it adapted and passed on to the child in terms which he or she can understand and in an environment with which he is familiar, there is the other important aspect of allaying the fears of the parents themselves. Most of the time, these are unfounded, or either they are founded upon erroneous information. But nevertheless, it is an important aspect of the preparation of the child to give information in such a way to the parent that there are no concerns or undue concerns in regard to the coming hospitalization. All of us are very familiar with how rapidly one's feelings can be transferred to the child. And thus, in preparing the parent for passing this information along, we are at least setting the stage for a healthy approach from the standpoint of their own concerns and worries. An anticipation of the coming operative procedure is a very real part of any adventure. I suspect that much of the anticipation constitutes most of the happiness associated with many experiences. The actual realization may not be nearly so significant as the prior thoughts concerning it. And in this healthy anticipation, this mood of the approach toward hospitalization, there are certain aspects of this which are of some consequence in terms of timing. It makes very little sense, it seems to me, to begin discussing with a 2- or 3-year-old his coming hernia operation several months in advance. He has a very difficult time waiting until the afternoon when he's told in the morning that his father will come home a little bit earlier from work. To prepare that child at that age by a long series of discussions makes very little sense and can certainly not contribute very much to the proper preparation. On the other hand, an older child, 10, certainly school age, may benefit tremendously from a prior opportunity to discuss his coming hospitalization and perhaps to express some concerns about it and be given the opportunity to have these explained in due course as his hospitalization nears. So that the timing is certainly age dependent and should be then tailored to the child and his own emotional and chronologic development. I would like to emphasize the sequential aspect of this adventure because many children have their first contact with hospitalization when their grandmothers or their great aunts enter the hospital with a terminal illness. Often the hospital is a one-way street, and many children will not be able perhaps to express this, but are very much concerned about hospitalization because it may constitute a dead end. Therefore, this circle of the adventure, going from the home into the hospital for an operative procedure and coming back home, is an important sequence to the child. Now, there are a number of ways that this can be gotten across, obviously. Reading about a hospitalization in which there is preparation for going is a very helpful way because all children like to be read to. Play acting is also a very valuable way in which a child can become familiar with the hospital environment in a way which is acceptable to him and does not constitute any threat to him as he approaches this new experience. And I would like to particularly emphasize the family participation aspect of this preparation, because if other members of the family, the brothers and sisters, can be a part of this and can be looking forward to the child's return with all of the glowing stories, most of which are overemphasized, of course, of his hospitalization, this can be a very real part of his adventure and one that he can look forward to in terms of returning to tell them about the tales of his heroic deeds in another environment. The importance of rooming in mothers, and I think it's particularly appropriate to mention this to a surgical audience, because many of us, by our training background, I think, are reluctant to have parents participate in the hospital experience of a child's operative procedure. We're very satisfied to have them do everything at home, to come in occasionally, and then to take the child home, but to have the mother, or occasionally the father, in the room during the time the child is being evaluated and subsequently managed postoperatively is a new experience for many of us. I've become convinced that for the preschool age child, rooming in mothers can be a very real help, not only in the day-to-day mundane management of the child's needs, particularly on services where we no longer have nursing personnel who can do everything, but to participate in the child's environmental needs is simply out of the question. And so the mother not only fulfills this important role, but also, from some feedback now from several years of dealing with rooming in mothers, this can be a very valuable experience for the mother in terms of her aftercare of the child. This becomes particularly important in the chronic diseases for which our operative procedures are only palliation, where the parent can become much more familiar with the management of these problems and have a chance to see that this does not represent a major threat either to the child's activities or to his future functional integrity. In many new hospitals now being built, provisions are being made for rooming in. At our own institution, there is no charge for the mother rooming in, and she is given her meals. In other words, in a very real sense, we are paying her for being a part of our paramedical personnel and participating in the nursing service. And I think they can be exceedingly helpful. I would emphasize that this is especially true in the short-term admission. The child who is brought in for a tonsillectomy or for a hernia repair, who is only going to be in the hospital for 2 or at the most 3 days, where there is not an opportunity to relate to the in-hospital personnel, to become a part of this new environment, to be able to bring a part of your home environment with you in the form of your mother is apparently a very valuable type of tie to this circle of the sequential adventure. Now, of course, the role of the surgeon is very well known to each of us, but let me emphasize just a few aspects of this. A discussion with the child and with the parent is exceedingly important, and it probably should be carried out, at least in its basic aspects, with the child and parent both together, because then there is no problem about telling something to one and not to the other. Now, obviously, in the child under 1.5 years or 2 years of age, not very much discussion is going to be applicable. But for the child who is preschool and certainly school-age children, some discussion in the office before hospitalization is exceedingly important and gives the surgeon an opportunity to establish with the child the fact that he is going to participate in the hospital experience and can even occasionally mention some of the aspects of the environment in which he's going to participate. This preoperative contact then with the postoperative environment is the first aspect of his inpatient experience. And I cannot emphasize too strongly the importance of taking a child before his operative procedure into the recovery room area or intensive care area so that he can become familiar with what he's going to see when he wakes up prior to his operative procedure. It seems to me that this is the only way we can expect a child to look upon this rather threatening environment as perfectly normal. The simple description of the after effects of the operation have come home to me on a number of occasions when a child accused me of hurting him or injuring him with the operative procedure, which I had so beautifully described to him, but had forgotten to mention that he was going to be sore in that area, or there would be a bandage there, or there was some evidence of trauma. This mentioning of the after effects of a tonsillectomy, for example, is exceedingly important in maintaining any type of relationship with a child who otherwise has such a sore throat that he cannot swallow. A rapid return to normalcy, again I would emphasize, with every aspect of the hospitalization is an exceedingly important part of getting well. If a child is treated as though he is sick, he will remain sick. And as long as he's in bed and being waited on at home, this means he's sick. And he will continue to feel that something must be wrong with him unless he can be mobilized as rapidly as possible. How do we go about approaching some of these aspects of the in-hospital environment? In our intensive care areas, there are more and more monitors, various types of oscilloscopes, and instruments used for recording various physiologic reactions to the surgery. But I would like to mention to you that two twin oscilloscopes do not look dissimilar to many of the robot monsters which are present on television. And I have had more than one child say that that eye was looking down to find out exactly what he was doing during the time he was in the intensive care area. And I think these represent considerable threats, not only to children, but to parents. And parenthetically, we bring our parents into this environment also prior to the operative procedure if we possibly can, so that they will not be concerned about the various instruments present therein. And the patient shown one of these monitors, a chance to look at it, to touch it, to talk to it if he wishes, and to feel his way around before he's had his operative procedure, and therefore must lie there uncomfortable, concerned about his environment as well. One of the concerns of children is the oxygen tent. This is particularly applicable, of course, to the cardiovascular and thoracic patient. An opportunity to climb in this beforehand, also to get his mother to put her head in there, can be a very satisfying experience to the child in terms of realizing that this does not constitute any threat. The last time he heard about an oxygen tent was when his grandmother in congestive failure died in one. And therefore it's of considerable consequence to see that this can be just a part of the play things which are present in the intensive care area. Feeding children in a hospital has always been carried out just like we feed adults. You bring the tray to the bed. But this is a very abnormal way of life for a child, and so in many of our newer hospitals there are areas within the play area where the children have their meals. This has turned out to be financially very satisfactory also, because one or two dietary personnel can take care of a child's food needs in such an environment where it takes many more to carry the trays back and forth to the child's bed. Post-operatively, these children will be bent over perhaps following their hernia repair, but they remember this is the place they had their picnic, this is where they're going for their meals, and so they're rapidly mobilized spontaneously and show up in the playroom for their meals on the same day of their operative procedure.
Thank you, Dr. Haller. The usual child who comes into your office with a mass in his neck presents no real problem, either diagnostically or therapeutically, but there are some areas that present difficulties. In his discussion of troublesome problems with neck masses, the University of Colorado's Jens G. Rosenkrantz describes 4 such types of cervical disease, beginning with cystic hygroma, a congenital anomaly that is seen rather rarely, but that can represent quite a problem for the surgeon dealing with it. Let's listen to Dr. Rosenkrantz.
The embryology of this lesion has been fairly well worked out on a theoretical basis, but I would caution you, like the embryology with any congenital anomaly, this is theory and there's very little evidence on which it can be based. In any case, I think it's important, as everybody has stressed, to recognize that this is not a malignant tumor, although there are many solid areas in it. This is a benign disease, in a sense, benign, that is, versus malignant. Cystic hygromas in the head and neck, of course, can pervade all the important tissues of the neck and can interfere with function, respiratory distress, and require a tracheostomy, and then later on required excision of this mass. This is as far as many of the textbooks go. Any of you that have ever done this surgery have realized it's extremely difficult. What I'd like to talk about is the type of case that you might see more commonly, where a child who is essentially asymptomatic comes into your office with a soft mass on one side of the neck, proved to be a cystic hygroma, and like many of them, what you see is merely the top of the iceberg. And the surgeon caring for a lesion like this must realize that if he is to excise this, he's in for a big operation, because these cysts do extend throughout the areas of the lymphatics, not only in the neck, but also in the contiguous lymphatic areas. Why do we operate on these patients? Well, basically, the patient presenting with an asymptomatic mass in the neck, which is a cystic hygroma, has, as near as I can tell from the literature, about a 25% chance somewhere along the line of developing infection in this. An infection in a cystic hygroma can be a very impressive illness and can be very life-endangering for the child, and this is primarily the reason that we do this. In any case, one of the demoralizing things as one surveys the literature with cystic hygroma is that we're not able to excise these lesions with as high a frequency as we would like. And I think in any series of any size where one has expert surgeons, in about half the cases, all lining of cysts cannot be removed out of these extensive hygromas. And the question then comes up, what do you do under these circumstances? There have been a number of suggestions. Dr. Gross, I think, was the first to recommend that the remaining cysts be left open, and reported a case in the mid-40s in which he had done this to mediastinal disease, had actually painted the cyst lining with tincture of iodine, and had gotten a cure. If you can't remove all the cyst, it isn't certain that the patient will recur and get in difficulty, because about half the patients where disease have been left behind have not recurred. But about half do, and the problem that I'd like to speak to is what do you do in those cases? In one such case, accidentally, we had dissected along the neck, removed a good deal of cyst lining from the neck, and then found that the disease invaded, if you will, the brachial plexus. Loath to take any chance on injuring these nerves, we merely marsupialized the multiple cysts. Actually, they're all in good communication. We sewed the lining of the cyst to the skin and then injected 50% dextrose over 3 or 4 postoperative days. This went ahead and healed. That's one. There have been 3 other cases that have been handled in a similar fashion. The first of those 3, the second patient that I've managed like this, was again a case in which I tried to remove the cyst, was unable to do it in its entirety, and settled for marsupializing what was left. And as far as I know, this patient as well. The last 2 have been patients where I've done this as an initial treatment. I don't know whether it's going to work out or not. It's a very small number of cases, and I'd like to throw it out for what it's worth, particularly when one's in a situation with extensive disease. You get in and you find that it does involve, as it frequently does, contiguous areas. The next subject I'd like to deal with briefly, because it's bothered us, and I think we made mistakes in dealing with this, has to do with tuberculous lymphadenitis. As you know, in the past 10 or 15 years, there have been increasing numbers of reports of patients who develop tuberculosis due to organisms other than the human or bovine tubercle bacillus. This is a large hodgepodge of organisms. The actual pathology and the actual organisms involved has varied throughout this country and throughout various areas of the world. What we see, in short, is cervical lymphadenitis due in our area particularly to scotochromogens, organisms which are slow-growing, which appear less pathogenic than human tubercle bacilli, but which appear to cause about the same type of pathology, and chiefly cervical lymphadenitis. Like human tuberculosis, these nodes can come up in a relatively short time. They can appear in a patient as an acute illness with a fever, with a sudden acute lymphadenopathy, which then becomes chronic. And in many of these cases, we initially began to treat these according to principles laid out for treatment of human tuberculous infection, and have not been able to treat them successfully that way. One of our difficulties is, at least in our part of the country, this disease is usually due to scotochromogens, and this is usually resistant to INH, PAS, strep, and other anti-tuberculous therapy. And we've relied really on the old principles of the management of scrofula and had to remove these surgically. We've had very little luck with INH therapy. The diagnosis, of course, has to be thought of, to be made. Once thought of, one can skin test patients with first human PPD, and many times you'll see a weakly positive reaction at the second strength. It is possible to obtain PPD for the atypical mycobacteria that seem to offend in your area. I would caution you that there's no such thing as atypical PPD. It depends on what strain this is for. The standard so-called atypical PPD was really for the non-photochromogens, the Bacillus, and at least in our area where this isn't an offender as often, the patients can be non-reactive to this. With such a positive tuberculin test and with the clinical suspicion that this is tuberculosis, we treat with excision. We hope to be able to do this before the mass fluctuates and before it drains, but certainly if there is a chronic fistula, we go ahead and excise this at the same time. We do not cover our patients with anti-tuberculous therapy merely because the organisms are usually resistant. I was talking with Dr. Sieber from Pittsburgh about this, and he does, and they have very good success treating this with INH, without surgery. So again, I would caution you not to necessarily go on what I say, but examine what goes on in your own area, because there is a good deal of variation. The results have been very good. The cosmetic results are relatively non-disfiguring if you can get the patients before they suppurate. Even if they do suppurate, it's many times possible to excise the nodes. It, of course, is a big operation, but the results have been good with surgical treatment due to scotochromogens. The third subject that I'd like to talk about is carcinoma the thyroid. Many of you care for patients with carcinoma the thyroid, not necessarily in the pediatric age group, and you realize that there just aren't any answers in this disease at this point. There's an awful lot of theory and an awful lot of people talking loudly about their theory, but there really aren't many answers. This is particularly true in the young individual. Dr. Winship from Dr. Randolph's area has collected, I think, all or almost all of the reported cases of carcinoma of the thyroid in children, and in about 80% of these, the lesion is a differentiated carcinoma. So in the pediatric age group, one doesn't as often have the problem with undifferentiated carcinoma. It isn't rare to see carcinoma of the thyroid in relatively young children. It isn't a disease that's confined to the teenager or the young adult. One of the real difficulties with carcinoma of the thyroid, particularly in children, is a chronic disease. It's cancer. There's no doubt about that. There was a rumor going around a few years ago that this wasn't really cancer and that these patients didn't really die. And I think there's increasing evidence that they do. But it takes 20 to 25 years for this disease, untreated many times, to run its course. And in Winship's survey, there were a number of cases of patients who had disease even in the lungs for periods of 15, 17, 20 years with or without therapy that went ahead and died, but died after many, many years. Now you can see, if you're going to base your therapy of carcinoma on the thyroid on 5-year survival or even on 10-year survival, it's going to be very difficult to differentiate between various types of therapy. The results ought to be good in everybody because the disease is so slow that it doesn't kill people very rapidly. Nevertheless, it does. And without a lot of fact to go on, there's been a lot of opinion, and I can only tell you what we do. I can't defend it. We've treated this as cancer, but not like cancer of the lip or cancer of the gum. It's not the same disease. And we followed what many people have advised with a hemithyroid, a total hemithyroid on the side of a nodule, a very careful inspection of the other lobe of the gland. If there are nodules in that, we usually do a subtotal resection on that side, and then we berry-pick nodes. Following surgery, we like to scan our patients. I think even though the patient has what looks like a pure papillary lesion, these cells do pick up I-131, and if you let the patient get mildly hypothyroid over 2 or 3 weeks post-operative, you can then scan them, and you can pick up nodes, and we've tended to treat these nodes initially anyway, with repeated doses of I-131. If one persists over several years or so, then we'll go in and remove it. There's been a lot of argument about whether one should do initial total thyroidectomy to start with. As you know, the incidence of at least microscopic metastasis on the opposite side is very, very high, even without palpable nodes. However, I would caution you that the incidence of recurrent disease on the other side is nowhere near as high, and it may be that many of these foci of abnormal cells don't actually go ahead and cause trouble. Again, there's a lot of mysticism about this because it's very difficult to get at the facts. The last thing that I'd like to talk about, and this is an area where I think I am being a little controversial, and that's the management, the surgical management anyway, of lymphoma. Hodgkin's disease is a disease of children. There's a lot of indirect evidence, epidemiologic evidence based on the incidence of the disease and the course of the disease that suggests that Hodgkin's disease in a young person is a different disease than Hodgkin's disease in a person over 45 or 50 years of age. In short, the disease in the younger age group tends to pursue a much more benign course. In many cases, it acts as if it's not a malignant disease. It acts as if it's a granuloma. There has been increasing evidence that there are patients with Hodgkin's disease in which there is a steady progression of involvement from one lymph node area to a contiguous lymph node area, progressing centrally and spreading much in the way that certain carcinomas spread. And based on this, a number of people have investigated treating actively and radically disease that's confined to lymph node areas. This treatment initially was radiotherapy. As you're well aware, with no therapy, a number of patients with Hodgkin's disease seem to live for a surprising period of time, but I think that, at least statistically, these results look better than no therapy. Now, based on this, several surgeons have tried to treat localized Hodgkin's disease surgically, treated, in this case, by radical neck dissection. And I'm sure you're aware of the work done by Dr. Slaughter in Illinois, and then, of course, by Dr. Pack in New York. And if the patients are carefully selected, it does look as if at least over a 10, 15, and in some instances 20-year follow-up, these patients can be successfully managed by radical surgery, sometimes with concomitant X-ray therapy, sometimes alone. We've been trying this on carefully selected patients. We really only treated a couple this way because if one keeps the criteria for selection fairly rigid, you must realize that this represents the minority of even children with Hodgkin's disease. I, of course, don't know and won't know for about another 20 years how well it works. What we've done basically is examine patients, assure ourselves that the disease is limited to one lymph node area, investigate other lymph node involvement by either X-ray of the mediastinum or, more importantly, lymphangiogram to outline the periaortic nodes, and then failing to find any other node involvement, have gone ahead and managed with the standard radical neck dissection.
Thank you, Dr. Rosenkrantz. And this, Doctor, is the end of this side of your reel. On side B, discussions of the management of undescended testes and postoperative monitoring of infants. And to hear these, simply reverse the two reels or cassette cartridge on your tape recorder. This is Side B, Audio Digest Surgery, Volume 16, Number 3, continuing the first of a two-part program on current approaches to pediatric surgery. It's been estimated that from 2 to 10% of all newborn babies have an empty scrotum at birth. This is perhaps 5 to 10 times more common in the premature infant. Such testes usually descend into the scrotum during the first year of life in most infants. If they haven't by that time, the chances are they won't. Now UCLA's Eric W. Fonkelsrud reviews some present-day thoughts in the management of undescended testes and elucidates operative techniques that he prefers. Dr. Fonkelsrud?
What we have tried to do in our grouping is to think of the undescended testis perhaps in a broad category of patients. That is, those with retractile testes, ectopic testes, undescended testes, and abdominal or hypoplastic gonads. These patients all have one common feature, and that is an empty scrotum. The retractile testis is by far and away the most common of these problems and should be excluded truly from the true undescended or cryptorchid gonad. These patients may vary in age all the way up to puberty, but rarely need surgical management. The ectopic testis, on the other hand, is a little smaller category and is one in which the gubernacular attachments to the testis have been a little more active in areas other than the scrotum. That is, either into the inguinal region, to the femoral area, the suprapubic area, or the perineal region by and large. Most of these are unilateral, at least 3/4, and bilateral in 25%. The truly undescended testis is perhaps the next most common after the retractile testis. This gonad has a short spermatic artery, and this is the limiting factor preventing its descent, although in some cases actually the external inguinal ring may not have opened to allow descent all the way to the scrotum. This occurs unilaterally about 3/4 of the time and is bilateral in 22%. The abdominal testis is an unusually high location of the undescended testis and perhaps should be actually included under that category. The hypoplastic or absent testis is again possibly in the undescended testis category, but because of frequently other abnormalities, endocrinological and others, it perhaps should warrant a separate category. Well, the reasons for testicular undescent are several. Certainly the premature infant may be born before the testis actually has a chance to get down to the scrotum at a time when the chorionic gonadotropins are circulating high in the mother. This may not have been sufficient to bring the gonad down. These testes frequently will descend during the first year of life, as with a full-term infant. But perhaps the most important feature is the mechanical barrier in the inguinal region, or the shortened spermatic vessels that prevent the testis from descending to the scrotum. And this is where the surgeon directs most of his attention in trying to correct this anomaly. The treatment of the mother with chorionic gonadotropins perhaps may be related to maldescent. It has been suggested by some. Intersexuality, patients who have endocrine problems such as Klinefelter syndrome and hypogonadism and other problems of this type, these patients frequently will have undescent. As many as 6 to 10% of children who have undescended testes fit in this category of having endocrine diseases. The intersexuality group perhaps includes patients with exstrophy of the bladder, exstrophy of the cloaca, and problems of this type in which there is almost invariably bilateral testicular undescent and failure of scrotal development. And this fits into this latter category as well. Well, now the indications for Orcheopexy are several. At any age, perhaps one should consider the presence of a hernia. Hernias are very common in undescended testes, and perhaps all have a hernia sac of some degree. An infant of 2 to 4 months of age that has an incarcerated hernia certainly should have his testis brought into the scrotum at the time that his hernia is repaired. And any infant who has an incarcerated hernia should have his operation at that time. The operation is done very much the same in this age group as it is in an older child. Torsion of the testis is a rather debatable issue at the present time, in that the previous statistics suggested that the undescended testis had a much greater likelihood of twisting or torsing in the scrotum. More recent data suggests that this may not in fact be true. In fact, perhaps these patients have no greater likelihood of torsion than do normal persons. So that this perhaps is not a great indication for Orcheopexy. Trauma certainly is an indication. The presence of a fixed gonad over a firm structure such as the pubis or in the area of the inguinal ligament is a strong indication for having this done before the child gets into body contact sports such as football, wrestling, and activities of this type. Pain, frequently associated with trauma, is another indication for repair in this group. After the age of 5 years, there are many other reasons for performing Orcheopexy. Fertility in bilateral undescended testes, examination for tumor. The incidence of malignancy in an undescended testis is considerably greater than in the normally descended testis, perhaps as high as 30 to 50 times more common. And the abdominal testis apparently has a greater likelihood of becoming malignant than does the inguinal testis. The chances of a tumor occurring in one of these gonads is not altered by the bringing of the testis into the scrotum, although the physician has a much greater ability to diagnose the presence of the tumor if it is in an area where he can feel it and examine it more carefully. So this is the reason that we feel that the testis should be brought down for the presence of tumor. Also, the cosmetic benefits. The cosmetic reasons for performing an Orcheopexy are certainly great. Many of us tend to overlook this all too often as a strong indication for performing Orcheopexy. But now the basic problem in the undescended testis is the fact that the spermatic vessels come down, go through the internal ring, the external ring, and then down into the scrotum. This triangular effect here takes a little longer vessel than if the vessel could come directly down into the scrotum. And this is the basic philosophy or feature of what is done in the Orcheopexy, and that is to bring the internal inguinal ring directly under the external ring, such that the spermatic vessel, the limiting factor in allowing the testis to come to the scrotum, can come down in as short a path as is possible. Now, the major features of Orcheopexy have been described by many, and these are merely the main points that Dr. Gross has recommended in the past. Adequate incision to permit liberal retroperitoneal dissection, and this really should be emphasized that to start with a small hernia incision is not adequate. This has to be large enough to expose the retroperitoneal area to allow an adequate dissection. Freeing of the testis from the surrounding attachments, including the cremasteric vessels, is certainly a very important feature, providing the testis can be brought down into the scrotum relatively easily. The division of the inferior epigastric vessels and construction of a new internal inguinal ring are major features in obliterating this triangular effect of the spermatic artery. Forcible stretching of the scrotum. These patients usually have a scrotum that has not had a testis present, and the testis will not descend to the bottom of the scrotum unless it is enlarged forcibly by finger dissection. And then a traction suture attached to the opposite leg for about 5 days. This is in the child that's 4 or 5 years of age by and large. If one has to perform an Orcheopexy in the small infant, the same general operative procedure is performed, only instead of pulling the testis down to the thigh, the small infant not tolerating this position very well, we have just used a small dental roll with a pull-out stitch of nylon suture over this area for about 5 days, following which this is removed. Now, the complications from Orcheopexy are relatively few if performed carefully without trying to hurry through the operative procedure, which usually takes an hour and a half to 2 hours to perform. The spermatic cord is subject to injuries, the vas, approximately 1 to 2%. The spermatic vascular injuries, somewhere around 2 to 3%. And these certainly are critical, all of these complications, which may lead to failure of testicular function at a later time. Retraction of the gonad to the external ring is perhaps the most common complication, if it can in fact be considered so. Usually this is due to inadequate mobilization of the spermatic cord to allow adequate length to reach the scrotum. Now, the most significant advances in the last few years in the management of undescended testes have perhaps been in the area of the very difficult testis to bring down. The high undescended testis, the one that is in the high inguinal canal or is in the retroperitoneal space or in the abdomen. These testes usually cannot be brought into the scrotum easily by just the extensive mobilization of the spermatic artery, but other techniques have had to be developed. The type of procedure that has been performed up to date has usually involved a 2 or 3 stage operation in which the gonad is brought as low as it can go, usually around the external ring, hopefully coming back a few years later to do a little more mobilizing to bring it into the scrotum. Some have even suggested if the testis can't be brought all the way down that the testis should be excised, and I think this is actually an admission on the part of the surgeon that he just can't handle this problem. Even though the testis may appear normal grossly and have a normal histologic appearance, we would strongly recommend that that gonad not be excised. Well, in these very high undescended testes, we've obtained considerable knowledge from Melbourne, from Dr. Fowler, who has suggested that the spermatic artery be divided in these patients, which then bases the vascular supply not on the spermatic artery, but the vessels that come with the cremasteric muscles and with the vas, and that these, in fact, may be sufficient to provide adequate vascular supply to the gonad. As we mentioned earlier, the vas is usually not a limiting factor in permitting descent of the testis all the way to the lower portion of the scrotum. This has indeed now been performed in many institutions in our country as well, and the testes do appear to have good vascular supply after this procedure has been performed. The only point in which I have had a little skepticism of this is that none of these patients, to the best of my knowledge, have gone on to have the opportunity of procreation to see if their sperm count is entirely normal. The presence of a normally appearing or grossly appearing normal testis does not necessarily go hand in hand with the presence of a normal spermic testis, and I think we'll have to await the results from Melbourne in a few years to more critically evaluate this procedure. If the testis is not found during the inguinal exploration, which is quite rare usually, we would recommend exploring the abdomen before diagnosing agenesis. It's frequently the case that the testis actually is in the retroperitoneal space, but it just has not been found, and once in the abdomen one can usually pick it up and then bring it down. If the testis is atrophic or less than quarter normal size and the patient is beyond the 5 or 6 year age group, an orchiectomy perhaps should be seriously considered. If the testis is absent, if one cannot find one, or if this is truly an atrophic testis, then one probably should insert a prosthesis in the scrotum to allow this child to have a more normal cosmetic appearance. Now, the real area of concern is the presence of fertility in cryptorchism. An uncorrected testis usually does not mature beyond stage 2 of germinal differentiation, and this has been fairly well shown by extensive biopsy reports by UHER and Hines and many others in this country as well as abroad. The histologic proof of further differentiation of the testis that has been brought down by operation has been shown clinically by several. There are fairly good reports now that patients that have had bilateral undescended testes in which one testis was brought down at age 5 or 6 and the second testis brought down at age 15 or 16, that the first testis that was brought down has a normal histologic appearance at age 15, whereas the second testis does not. So that this is a good reason to seriously consider earlier operation on these children before the maturation of the testis becomes retarded. We do not have good evidence at this point that the testis that is brought down later will not catch up. But if the child is put off for a long period of time, one questions whether this will be sufficient to allow catching up of the maturation of the testis. Statistics from UHER and Hines studies have shown that by age 5, the normal germinal maturation for the age was close to 100%. From 6 to 10 years of age, 8% had normal maturation for age. And after that, no testes had normal maturation for their age. And therefore, they strongly recommend that the Orcheopexy be performed before this critical period, somewhere before the 5 or 6 year age group. One of the distracting features, however, is that in 6%, the degenerative changes are even more pronounced in the contralateral testis than in the one that is undescended. Well, this puts even more emphasis on the fact that the testis that is undescended should be brought down as early as possible to allow the best chance of its growing and developing well, if the contralateral testis is likely to be abnormal as well. In fact, tumors are likely to occur in the contralateral testis almost as frequently as in the undescended testis. With untreated bilateral undescent, the patients that get to reproductive years, infertility is 100% according to some authors. If Orcheopexy for bilateral undescended testis is performed before the age of 5, up to 50% have been reported to be fertile and 31% to have normal sperm counts. In bilateral undescended testes, maturation is at the same stage in about 40% in both testes. They vary to some degree even if both testes are undescended. Androgen production apparently does not appear to be diminished in the truly undescended testis to any significant degree, in contrast to the patients who have endocrine deficiency states or other reasons for having dystopic testes.
Thank you, Dr. Fonkelsrud. The outstanding characteristic of the infant's response to stress and trauma is lability. An infant can be seemingly well 1 minute, in irreversible shock the next. This potential for rapid change demands use of the best monitoring techniques possible to pick up those subtle signs that can give advanced warning of possible serious changes in homeostasis. Let's listen now as our final guest lecturer this week, the University of Florida's James L. Talbert, outlines some important points in postoperative monitoring of infants.
One area, of course, where we find immediate application of monitoring techniques is in the field of cardiac dynamics. As we well know, it's impossible or impractical in the small infant usually to obtain auscultatory blood pressures. And in these infants, we find the technique of umbilical artery catheterization and umbilical artery monitoring extremely valuable. We use small, tapered, radio-opaque polyethylene catheters for this purpose and feel that these should be positioned under fluoroscopic control. This avoids the danger of inadvertent cannulation of the distal arteries of the leg and the possible consequences thereof of inducing ischemia of the lower extremities. These catheters not only give us a means of monitoring blood pressure, but it also provides access to obtaining serial blood samples for determination of acid-base balance, electrolytes. It also gives us a method for infusing fluids in these patients. Of course, in the older patient, we can use the temporal artery in the head, the arteries in the arms, or the femoral artery in the groin. Another area that demands monitoring is that involving thermal regulation. Certainly any of us caring for these infants fully appreciate the need to maintain body temperature. It's probably only now, however, that we're beginning to fully appreciate the various ramifications as far as physiologic effect is concerned, as they're related to sudden drops in temperature in the infant. We have the usual isolate available to us for maintaining the warmth of the infants in the pre- and postoperative period. In certain instances, the usual isolate has proved impractical to me, particularly in cases where we're administering respiratory support to the child. In these cases, the isolate effectively screens the child from the nurse and the surgeon within a box of plastic. And this Saracen type of cradle warmer improves the access and allows you to treat the patient under conditions of emergency. The top can be raised or can be completely removed under some circumstances. This can be regulated with a skin thermistor probe of the same type that's available on the usual isolate. We're all aware of the necessity for monitoring temperatures and maintaining body warmth during the operative period as well as in the pre- and postoperative period. I might also mention that it's equally important in the older child who's being treated for various types of inflammatory conditions that the body temperature be monitored for just the reverse reason. Under these circumstances, you're worried about possibility of hyperthermia rather than hypothermia, and it's necessary to cool the patient in many instances. We also might mention the use of monitoring techniques in relation to respiratory support in children. I won't go into the usefulness of various types of ventilators and tracheostomies and so forth, but I would like to mention the apnea monitors that are triggered by electrodes on the chest wall. When the child has a spontaneous respiratory arrest, an alarm is set off which notifies the nurse. In most instances, these respiratory arrests in premature infants are treated quite simply with stimulation. However, if they're allowed to progress untreated, then of course it can prove disastrous. Another area in which monitoring lends itself extremely well is that related to fluid and electrolyte regulation. I think in the early 30s and 40s there was a great deal of trouble with overhydration of infants. And as a result, various types of maintenance fluid formulae were devised which have proved quite helpful. However, as a result, in the 50s and 60s, in many instances, it seemed that in some cases we were underhydrating these patients. I think that this also carries with it a significant penalty, not only in diminishing peripheral cardiac perfusion and interfering with cardiovascular dynamics, but also inducing increased respiratory complications through the formation of thick, viscid secretions. In order to avoid the hazards of under or overhydration, we felt a monitoring routine with serial determinations of central venous pressure, total serum solids, hematocrit, and urine-specific gravity, together with precise calculations of intake and output, has been extremely helpful. Certainly everyone in a sophisticated audience like this is fully appreciative of the usefulness and the physiologic approach of central venous pressure monitoring. I would like to emphasize, however, that if the inferior cava is used for monitoring purposes in these infants, I found on occasion that you can obtain erroneous readings. We were interested in this several years ago, and at that time carried out some experiments in dogs and subsequently applied this in humans, and found that in the case of increased intra-abdominal pressure, there were serious alterations in the inferior caval pressure. With infusion of air in the abdominal cavity through the catheter, there was a concomitant rise in inferior caval pressure with no significant alteration in the superior caval pressure. As we well know, in the postoperative period, in association with ileus, there is frequently an increase in intra-abdominal pressure in these infants. Also, of course, the infant is primarily a diaphragmatic breather, so that he tends to accentuate these changes. So that we feel that in these instances where there's any question of a possibility of increase in intra-abdominal pressure, that it's essential that the central venous pressure be ascertained in the superior vena cava. Again, we face the same problem in these small infants of exactly how to do this best. Obviously, it's very difficult to insert a catheter through a peripheral vein up into the superior cava, or even perhaps to cut down on the cephalic vein in the deltoid groove. In some instances, it'll be possible to insert catheters percutaneously into the subclavian vein. But in most cases, we feel that the best approach is through use of the external or internal jugular vein in the neck. In the older child, you can again insert the catheter percutaneously into the external jugular vein. In most instances, in the very small children, you'll need to do a cut down. In some of the prematures, however, in newborn infants, we found that a preferable approach has been the use of the internal jugular vein. We use the same type of incision that we would use for the external jugular, a short transverse skin incision over the medial aspect of the sternocleidomastoid muscle. This incision will subsequently heal quite cosmetically and is perfectly acceptable. And with retraction of the sternocleidomastoid muscle laterally, you invariably can expose a large caliber vein. This vein allows insertion of a good-sized catheter. We prefer to use hyalastic catheter material for this purpose. We feel that it's better tolerated by tissues, it's less likely to clot, and also it's somewhat softer than the usual polyethylene materials and is less likely to inadvertently allow you to puncture the wall of the vein distally. There are certain hazards in using any type of prolonged intravenous cannulation, and I think it's pertinent to emphasize these. We like to discontinue our infusions as rapidly as possible in order to avoid the dangers of thrombophlebitis and infection. We like to avoid infusion of sclerosing solutions whenever possible. However, in this regard, I should emphasize that if you do find it necessary to use hypertonic solutions, then it's best carried out through the superior vena caval cannulation. You obviously want to get as large a caliber vein as possible to infuse these hypertonic solutions. Investigators at the University of Pennsylvania in the past year have emphasized the usefulness of prolonged parenteral support, particularly in small infants with congenital GI disorders. And over the past 3 or 4 years, we've had similar experiences at Hopkins and subsequently at Gainesville with this type of approach, using 10-20% glucose solutions, 5% protein hydrolysates, and 3.5 to 5% alcohol solutions. We've been able to maintain body weight in children from newborn period up to 3 years over a period of a month, solely on the basis of parenteral infusions, and in some instances they've actually gained weight. I would also emphasize that we apply topical antibiotics daily about the catheter as it enters the skin, and feel that this is extremely helpful in cutting down the incidence of infection. Another technique that's helpful in maintaining patency of these central venous catheters is the use of a constant infusion pump of the Harvard type. This not only allows you to guard against inadvertent thrombosis of the cannula, but it also simplifies the nurse's role. She doesn't have to run back and forth constantly to check the speed of your IV drip, since you can simply check this unit occasionally. If it's set properly, there's no problem with it. In monitoring central venous pressures, I think it's pertinent to emphasize that there are certain pitfalls. First of all, the use of inadequate technique. The catheter must be positioned in the central venous system in order to obtain adequate pressure recordings. Secondly, you want to be sure that there's no mechanical obstruction to your catheter. For this reason, it's critical that you check the position of the catheter once it's inserted. If you're using radiopaque polyethylene material, this can be done quite simply with an X-ray. But even with silastic cannulas, which are not radiopaque, you can obtain the same result by simply injecting a very tiny amount of hypaque and again obtaining an X-ray and checking the position. Finally, it's critical that proper interpretation be applied to these readings. Occasionally you find a single determination in itself is relatively meaningless, and the only way that you can gain insight into the true response to therapy is by obtaining serial determinations of central venous pressure recordings. As I mentioned previously, in addition to the central venous pressure determinations, we also feel that it's important to obtain simultaneous micromatocrits and total serum solid readings. The microhematocrit determinations, of course, are quite simple. These catheters that we've just discussed simplify this aspect of care in that you can very easily obtain your blood sample through the catheter rather than sticking the child. Once you've gotten your microhematocrit determination, you can break off the top half of the tube containing serum and allow it to drain under the cover slip of the hand refractometer. By holding this refractometer up to the eye with the light source shining from above into this cover slip, you can define a nice meniscus which gives you a direct reading of total serum solids or refractive index. This reading in turn is a very good estimate of total serum protein content. The total serum solids of venous blood is an accurate reflection of the total serum protein content. In addition, capillary samples will give you the same type of recording. I might mention that this same refractometer can be used for estimates of urinary specific gravity using simply a drop of urine. In some instances, we find these monitoring routines can become quite complicated. It's relatively few patients, of course, where you'll want to use each of these routines, but there are a number of patients where one or more will be applicable. At times, you may find the thoracic abdominal x-ray to be extremely helpful in checking the position and verifying the presence of the monitors. The position of the nasotracheal tube is easily established. You can be sure it's not blocking the bifurcation of the trachea. You can see the position of the intra-arterial catheters. And finally, you can verify the position of your electrodes for monitoring temperature and for electrocardiographic recordings.
Thank you, Dr. Talbert. And this concludes this first part of our two-part program on current approaches to pediatric surgery. Audio Digest Surgery is produced twice each month by the Audio Digest Foundation as a nonprofit subsidiary of the California Medical Association. All rights are reserved.